very good morning to everyone. At the outset, I would like to thank Tata Memorial Center and Dr. Ravikant sir, Dr. Bhartendu sir for giving me this opportunity to present on this topic, which is challenges in non-muscle invasive bladder cancer, guidelines to new clinical trials. So I would be giving a brief overview of the non-muscle invasive bladder cancer and the role of, as a urologist, our role in the management of the disease. Also, we'll be discussing what are the challenging situations we face from a urologist's perspective. There will be references of the recent clinical trials and what the guidelines say. So this is the first preceptorship program. I'm glad to be a part of it. So what are precepts? Precepts are guidelines, what we understand in medical terminology. In simpler Hindi words, they are Niti Vachan. Niti Vachan. So that is what we have to follow. We have to aspire to follow them. How far we are able to do it in our practice, let us see. So we have already discussed about the epidemiology and the global burden of disease and the Globocan data. So this has been already discussed. This is just a representation of the worldwide trends, and this is data from the UK, which showed that due to smoking cessation programs and several efforts, the incidence rates initially declined in the 90s, but later they plateaued, and largely, if I sum up, it's because of the increasing life expectancy. We are lifelong, these patients. So as urologists, we are sometimes lucky to be involved in treatment of early stage of the disease, making some significant therapeutic interventions possible. Even we are able to achieve cure with simple surgical procedures. This is the Indian scenario. Dr. Ravikant has already illustrated the specific cancer registry. I was not aware that we have a specific cancer registry for Muzaffarpur. This is what I could find, and this just shows the increasing trend in the Delhi. You can see that rising trend that is in the Delhi population-based cancer registry records, and we know that India still has a burden of around 19,000 new cases per year, and out of which 10,200 cases they die per year. So that is basically a very concerning factor, probably because of the late diagnosis. We also know that earlier this was touted as a disease of the developed world, but the global data suggests that nearly half of the bladder cancer deaths are occurring in the developing world. The most important reason for that is perhaps a lack of access to proper health care, and because of the long follow-up nature involved. This is another data from Tata Memorial Mumbai, and this is also showing a trend, a rising trend. Perhaps this is because of it being the referral center, and they are getting more and more patients. Now, after that, let us focus on non-muscle invasive bladder cancer. What I have tried to illustrate in this slide is these are the three subtypes with which we are concerned in non-muscle invasive. That is carcinoma in situ, TA and T1 disease. So what is carcinoma in situ? It is a high-grade flat malignancy confined to the urothelium. So it does not invade the basement membrane. But as rightly pointed out by sir, carcinoma in situ is sometimes wrongly thought as a pre-malignant condition like in other cancers. But in bladder cancer, it is already a high-risk disease. It is already a high-grade and basically associated with very poor prognosis, even especially if multifocal. So what is TA? TA, as you can see, they are papillary tumors, low grade, confined to the urothelium, and then there is a T1 disease in which there is tentacular spread usually in the into the lamina propria, and that is T1. So it doesn't invade the muscularis propria. So that is what is illustrated in this. This is just about the burden of disease. We can skip this. The presentation, usually three types of presentation. Painless, gross hematuria, the most common presentation. This is how we get our patients. 50%. The important line is that 50% of people having gross hematuria will have an identifiable cause, treatable cause, and 20% of that will turn out to be malignant. Microscopic hematuria is defined as more than 3 RBCs per high power field, and there is a 2.6 to 5.2% risk of malignancy. So that also needs to be taken care of. The third presentation is of irritative lower urinary tract symptoms, urgency, frequency, such symptoms, and they are more commonly seen with the carcinoma in situ disease. Now the initial evaluation. So initial evaluation, it is almost a consensus with most of the guidelines that a thorough history and physical examination is a must. And after that, an office cystoscopy is usually suggested in the guideline. And if there are any enhanced imaging, tumor visualization modalities like narrowband imaging, then they should be utilized. But the problem in our scenario is that office cystoscopies are generally not feasible, so we do a formal cystoscopy usually under anesthesia, and we try to combine just the diagnostic and the therapeutic part. Narrowband imaging and other modalities, I will be coming to those in the further slides, but they are also cost intensive, not usually available in every setup. Then an abdominopelvic imaging is a must. That is usually CT urography, and preferably before a TURBT. Before the TURBT you need to do it. Then cytology, a baseline urinary cytology is must, and the role is to identify a high grade disease, cytology, and also that sometimes the patient comes with hematuria or significant lower urinary tract symptoms and is cytology positive, but there is no visible lesion in the bladder. So that makes us suspect that probably this is carcinoma in situ. So what our mind knows, then our eyes will try to look for it. So that is one scenario where we have to think on those terms. So cytology is a must. Mostly comes out negative, but still for high grade disease it will be it is going to make our life much easier in decision making. Also, it is emphasized that in the initial evaluation itself, you have to screen for smoking and try to counsel the patient to, for smoking cessation. The EAU guidelines on initial evaluation have discussed certain debatable points, like whether to perform a baseline CT urography immediately once the bladder tumor has been detected. So that has been questioned for smaller tumors. Now they say that it can be omitted, and because they found that there is a low incidence of significant findings associated with certain tumor characteristics, smaller tumor, solitary tumor, for those cases, given the clinical scenario, you can go ahead with an office cystoscopy or even a complete resection in the first go if possible. The incidence of upper tract urinary cancer is low, but increases to 7.5% in tumors located in the trigone. So for such tumors, there is high chance that we might miss the upper tract and there is a field change, and so for those cases, a CT urography is a must for the location for such tumors. Ultrasound cannot replace CT, but has moderate sensitivity to wide range of abnormalities in upper and lower urinary tract, but it cannot rule out all potential causes of hematuria. So this is about the EAU guidelines, and then the multiparametric MRI, it has not yet been validated, but the initial systematic reviews have shown that it can reliably distinguish non-muscle invasive bladder cancer from muscle invasive bladder cancer, and a VIRATS reporting system has been developed. As we know, such kind of reporting systems exist for most malignancies like VIRATS, and similarly they are trying to validate this. Initial systematic reviews, because this is otherwise no CT or other cross-sectional imaging can reliably guide us about the muscle invasive nature, which is the critical point in decision making for this disease. This is a promising modality. Let's see how this evolves in the future. Again, about the urinary cytology, it has already been discussed that it should be a standardized reporting system. The Paris system is followed by most of the pathologists, and a freshly voided urine sample needs to be sent. An overnight sample should not be used because of high incidence of cytolysis, and cell destruction. So, and they have a high sensitivity for high grade tumor, high grade, that is G3, or high grade, now it is called high grade. So this is there. So I've already discussed about a positive cytology but a negative cystoscopy. So the guideline statement is the second statement in the slide, that voided urine cytology is an adjunct to cystoscopy to detect high grade tumor. Recent advance in this is that they are using an artificial intelligence algorithm combined with a digital image processing to select the cells which are more likely to be cancerous, and then they are reporting on the same lines, hyperchromasia, the ratio. So this is one of the tests that is commercially available in Western world, VisioSit test. So I got this information. It was new for me also, and I wanted to share this with you. That constant work is going on to make the diagnostic algorithms more efficient. Then the role of urinary biomarkers which were like the fluorescent in situ hybridization techniques, the NMP22, transdeluminase reverse transcriptase, and microsatellite analysis. They may identify patients more likely to experience disease recurrence. Then there are novel biomarkers which promise, like expert bladder, which promise even higher sensitivity. But their potential applications are for a patient with hematuria, for the primary detection. A patient with hematuria, but it is not the most reliable test. But yes, potential applications. Other is in surveillance. When we are doing surveillance cystoscopies, they have been investigated whether these biomarkers can postpone or avoid a cystoscopy, because it is an invasive modality. But unfortunately, no biomarkers have been so far been validated to replace cystoscopy or even to reduce cystoscopy frequency. That is not based on biomarkers. Even if we are reducing the frequency, that is based on the clinical factors, that the tumor characteristics, the reports and everything. It cannot be solely based, this biomarker is negative, so let us postpone his cystoscopy, or let us increase the, let us make it less frequent. So now coming to from the urology point of view, let's discuss what we do about cystoscopy and how we manage it. So this is a necessary diagnostic modality. Description of all macroscopic features and mucosal abnormalities must be done. So there is this bladder diagram which is mentioned in the EAU guidelines, and this suggests that you have to follow the reporting of the report of the cystoscopy should include these areas. So you have to look over these areas specifically, see for any obvious tumor, their characteristics like number, side, they're broad based or it is based on a narrow stalk. What is this characteristic of the tumor? Also, if there are any mucosal changes like red velvety, as Dr. Gaurav pointed out, red velvety patchy areas, so they should be suspected for CIS and a biopsy should be taken. So numbers are not readable, but yes, we have to inspect the trigone first, then at the bilateral ureteric orifices, then the lateral walls, posterior wall, then anterior wall, and dome of the bladder. So all these areas, once they are scanned, then in the end, while coming out, we look at the bladder neck specifically, and also the prostatic urethra or the posterior urethra. So they have to be reported like this. Just to standardize the reporting, this has been done. So we have to obtain a TURBT, transurethral resection of the bladder tumor specimen, or a cold cup biopsy specimen. So what are the challenges? Newer methods of tumor visualization are available. Photodynamic diagnosis uses photoactive porphyrins. They are intravesically instillable porphyrins are available, and hexaaminolevulinate is the agent that is used. It is instilled in the bladder, and after that cystoscopy is done under a blue light. The spectrum of the filters are used, a blue light is there. In the blue light, it is taken up more by the hypervascular tumor and they glow as pinkish. So this has a higher sensitivity but a lower specificity owing to false positive in the inflammatory or post BCG cases, because those also will have some hypervascularity capillary level, and they may lead to, so this is the drawback, that they have a lower specificity and a false positive rate. Then another method to avoid any kind of instillation or any kind of drug, because they used to cause photosensitization. Although hexaaminolevulinate does not cause that systemic photosensitization, but still narrowband imaging is based in the technology itself, the scope and the camera system itself. So here they are using two wavelengths which are absorbed differently by the mucosal layers and by hemoglobin. They are using it in the 415 nanometer and 540. The green and the blue range they are using. They are using filters in the white light itself. So that will be differentially absorbed by the blood vessels and the mucosa, and that contrast is used to identify any missed tumors. So areas which can be missed as a catheter related cystitis or some other kind of infective, UTI related cystitis, they actually show up very well on these. But the problem with these is that you need to have that camera system which is enabled with this. Another one was Image 1S. This is from Stores, and they also use a similar kind of algorithm, computer-based processing. So what is the impact? Impact is that in a systematic review and meta-analysis, in a very recent study, they have shown that it improves the diagnostic accuracy. Either you use whichever, PDD or NBI, over the white light cystoscopy that we normally use. So it is increasing the diagnostic accuracy. But what about the recurrence rate? What about the overall survival? The recurrence rate was also shown that, what I'm trying to say in this slide is that they did not reduce the recurrence rate in many studies. The advantage that was seen in the first 18 months was not reproducible at a later part of the follow-up, and they are cost intensive. So all these are the criticisms whether you should do it regularly. But NCCN guidelines also, they say that if you have them, then you better use them. Naysayers will say there is no much advantage, but when you see these this kind of images, then you want to say that there should be a scan with this kind of, and it really helps him. So levulinate, and then you do a blue light cystoscopy. This area lights up. It becomes pink. While the background is bluish, it becomes pink and it shows up. This is another white light compared to blue light cystoscopy. These patches can be missed for any catheter related or any trivial kind of benign kind of cystitis condition. But in blue light cystoscopy, if this is the picture, then they must be removed completely if possible, or at least biopsy with a deep biopsy. Then this is the NBI image. Here the appearance is slightly different. The concept is the same, but the appearance is slightly different. The normal vessels, they appear greenish, and the tumor appears brownish pink, I would say. So here also you can see that it becomes much more prominent, and any confusion you can just, and this light system is fairly easy to use. There is a button in the system. You just switch it on. The light changes from the left side to the kind of image on the right side. It just at the click of a button. So this is one advance, recent advance that we can say. This is also, the appearance is similar, but the technology is slightly different. This is from the SPICE system, and they use two spectra, the spectra A, spectra B modes, different modes. One is to highlight the tumor and one is to highlight the blood vessels. Okay, once we have identified the tumor, now what is the next step? Next step is the endoscopic surgical management. This is transurethral resection of the bladder tumor, TURBT, under a regional or general anesthesia is the initial treatment for all visible lesions. As we can easily imagine, they will biopsy the tissue for us. Also, if the tumor is of a limited nature, it can become therapeutic also. The bimanual examination of the bladder is often performed with the patient under anesthesia before painting and draping, and that is just to assess the clinical stage of the disease. Bimanual examination means that we pass a finger in the rectum and we do a suprapubic with the dominant hand we do a. So basically, performed by either a fraction or an en bloc technique is essential. So either you can do this resection in a piecemeal manner, you start from the edges and then you go at the main stalk and then you remove the complete tumor, or you can use an en bloc resection, which is currently considered to be the better method of resection. Lot of work is going on. What energy source needs to be used? It can be done with any energy source, but yes, the appearance is different. We will see in the coming slides. But the advantage is that there is no cautery artifact, and for the pathologist, it's easier to identify. There is high quality resected specimen that you can get, and also it identifies the underlying detrusor muscle in fairly large numbers. More than 95% cases you can identify the muscle. Now this is a basic principle of resection for any circulatory tumor for us, that the margin of the tissue should be removed, not just the tumor itself, because the tumor usually has some amount of deep spread. There can be two kinds of spread, broad-based or tentacular, and the prognosis depends on this factor also. Broad-based is considered usually poor prognosis. Now, what are the drawbacks of en bloc? It can be applied to very selected tumors. The whole tumor, en bloc means the whole tumor is removed. So, only one third are usually amenable, because some tumor located at the orifice, you cannot do it. A bulky tumor, even if you do it en bloc, you have to cut it anyways to take it out. So, so for more than 3 centimeter tumors, it is 2.5 or 3. It is not usually feasible. But yes, for papillary tumors, it is feasible. So, now what are the challenges? The challenges are to assign the disease risk, to identify CIS, then to do a clinical stage before that, then adequacy of resection. I would like to highlight on this the visually complete resection and the visualization of muscle at the resection base, or trying to send a separate biopsy from the base to get the muscle and to send it to the pathologist is one of the challenges for the urologist to do it, because it will bleed. These tumors bleed when you do it with the conventional way, and you have to clear everything and then take a separate biopsy from the base. Complications are always there in any surgery. Here the most important is to avoid a perforation, because that complicates issues. Then what is the indication of taking random bladder biopsies or mapping? Whenever CIS is suspected, then biopsies from the suspicious urothelium should be taken. Patient with a positive cytology and normal looking mucosa, then we should utilize photodynamic or NBI and take biopsies. So, what is the indication of prostatic urethral biopsies? Tumors at the neck or at the trigone, then sometimes we take a separate biopsy from the prostatic urethra. And this is okay. So let's just quickly wind up and see some images. This was incidentally my first case here in Muzaffarpur that I did. I did it in Saraswati only, and this was the tumor on the trigone, a large tumor. Initially, I was surprised that it looks broad based, but when I lifted it up, I found a stalk, and I was able to remove it completely. So this is the first case that I would like. Then there are these multifocal tumors. This patient was from follow-up from Tata Hospital only, and it was actually a multifocal tumor, and here also we were able to completely remove it. And this was another tumor of the same case. Now this is the laser en bloc resection I was talking about. So here you can see that there is a tumor, and with the laser, this whole tumor with the deep muscle is being taken, and this is the resected image, specimen, resected fossa, and the specimen. This is a monochlorine. That image, the laser we are about to acquire it here, not yet available. I have sourced it from somewhere. But this was another en bloc resection that I did from with a regular monopolar cautery. But you can see the depth is unreliable. With the laser, what happens is the depth of resection is quite fixed. It is 0.1 to 2 mm, and so you can do a precise. Now these are some challenging scenarios. Tumors at the dome. Tumors at the dome is a difficult location to resect. There is risk of intraperitoneal bladder perforation, and deep biopsies we also find it very difficult. This was just the video to show that even after adequate resection, there are sometimes it is not possible to take a deep biopsy in the first go, and re-TURBTs are needed. So I have completely resected it, but I could not take separate biopsies for deep because of the risk. So these are challenging situations. Diverticular tumors, another challenging situation. The problem with diverticular tumors is there is no muscle, and straight away if there is any invasion, it becomes a T3 disease. If you try to take a deep biopsy, perforation happens, will happen if you take it. So that is you have to base it. This is the image of the diverticular tumor. You can see there is a depression and there is a tumor that is all T1 tumors, and also for to detect, because upstaging is noted in 15% of patients. 40% of patients will have some residual. You think you have completely resected it. If you do a re-TURBT, in 40% you will find some residual tumor, and 15% you will, which was reported as non-muscle invasive, the second TURBT specimen, muscle will be identified and invasion will be seen. So that re-TURBT, what should be the classical therapy? Mitomycin C is the most effective agent. Other agents are used in Europe, but this is what we use here, and should be administered within 6 hours for the best advantage. And after 24 hours, there is not much advantage. But the problem here is that there are some side effects, and if any suspected perforation is there, you cannot give this perioperative intravesical instillation. This is actually to reduce the recurrence. And also, it has been seen that for low grade it is advantageous, for high grade this has not been shown. So there is a debate around this also. Now I would like to conclude my slides here, because the further topics, risk stratification and follow-up, risk stratification and further therapies will be discussed in the coming topics. About follow-up, I would say that bladder cancer needs a surveillance protocol. So we as urologists are involved in that also. Non-muscle invasive bladder cancer, we have to do regular cystoscopies. The first cystoscopy at 3 months from TURBT is considered to be the most important prognostic factor, whether you are able to find any new tumor or residual tumor, and you have to reassess it. And also how long it should be done, there is another debate, there is another challenge, that you have to convince your patients to get a re-TURBT done. You have to, the awareness, cancer awareness, I would say, is very important for that. Otherwise, patients are not able to understand what is the importance of follow-up. Ayushman Bharat has made life easier for urologists actually to follow the guidelines. Otherwise, patients were not. So this okay. So I would just like to conclude at that point, because lot of more topics need to be discussed. Thank you.